Olivier Cartiaux.
Good morning, everyone. I would like to thank Materialize and SME for inviting me today. Thank you for the USB key also, you saved me. So I am a young researcher with less experience than the two previous speakers, so I will try to do my best by giving some engineering aspects on how we can build evidence on accuracy of PSI technology in orthopedic surgery. These are my potential conflict of interest. I have read that I have got to declare everything, so I have declared everything, but I'm not sure all of this is a conflict of interest. I would like to thank my collaborators also. So the question I am working on since several years is do improvements in accuracy that we can reach with the new chaos technologies, namely navigation systems, surgical robots and PSI, do these improvements in accuracy impact the clinical and functional outcomes? Since several years, we are implementing an ISO methodology to collect objective and quantitative data on accuracy of bone preparation gestures in preclinical settings. We are also initiating a standardization process to harmonize at the international scale, to harmonize the accuracy definition and the accuracy measurement method in orthopedic surgery. And finally, in this presentation, I will illustrate the ISO methodology with the example of bone tumor surgery. This is an illustration of the clinical use of PSI technology for bone tumor surgery. First of all, the PSI is designed starting from the preoperative 3D CT model of the patient with the tumor. The tumor is in red on the left image. The cutting guide is designed to resect, to cut the tumor in one piece. Then the cutting guide is printed in 3D, and the surgeon is able to position the cutting guide in unique position onto the bony surface of the patient. And then the surgeon is able to replicate the resection planning directly on the patient. Currently, in the literature, we still have a few clinical studies or also cadaveric studies on the use of PSI in bone tumor surgery. In the field of chaos, computer-assisted orthopedic surgery, we have one dedicated standard, the standard F2554 from the ASTM. This standard is dedicated to the measurement of positional accuracy of chaos system, navigation system, and positioning robots. The good point with this standard is that it gives terminology, glossary of terms, as well as metrological and statistical concept when we want to measure positional accuracy of chaos system. But unfortunately, the procedure described in the standard can be very lengthy, and it can also be relatively complex to be used by an early user. Also, this standard is specifically dedicated to the measurement of the positional accuracy of chaos system, so it cannot be used for measuring directly the accuracy of bone preparation gesture, such as bone cutting, bone drilling, or positioning implants and prosthesis. So, since several years, we are implementing an ISO methodology for the preclinical testing of new assistive technologies. This methodology has the objective to quantify the improvements in accuracy of bone preparation gestures, such as bone cutting and positioning implant and prosthesis. And the methodology is considering the assistive technologies as do you see? Yes. Considering the assistive technologies as one of the factors influencing the accuracy of bone preparation gesture. So the clinical And the other factors can be the experience of the surgeon, of course, and the local difficulties related to the anatomical site. So the clinical relevance of the assistive technologies can be seen like this. If the improvements in accuracy of bone preparation gesture, the improvements in accuracy can allow for a reduced failure risk and also can allow for a smaller safety zone. I will illustrate this. When we define accuracy, we can refer to the standards 5725 from the ISO. In practice, when we have a series of measurements, of independent measurements, for example, a series of bone cutting measurements, we can define accuracy as a combination of systematic and random components, the trueness and the precision. The trueness is the systematic component of the accuracy, and it is defined as the closeness of agreement between the mean value of a series of measurements and target value, a reference target value. On the other hand, precision is the random component of the accuracy, and it can be defined as the variability among the results. It can be defined as the closeness of agreement between a series of independent measurements. Of course, this methodology requires that we define a surgical target, and in the case of bone tumor surgery, the surgical target can be simply defined as a desired safe margin in millimeter. Of course, definition of a surgical target is purely intrinsic to the clinical situation. Sometimes we can also define a safety zone, a tolerance interval on the surgical target, an interval above and below the target. And also, unfortunately, sometimes we do not know exactly, precisely what the surgical target is, and we can speak about an uncertainty on the target. In practice for bone tumor surgery, we have implemented this experimental protocol to investigate the effect of navigation and PSI technology for bone cutting during simulated bone tumor surgery, resection. So we have defined the surgical target as a 10 millimeter safety margin, so to cut the tumor with a security distance of 10 millimeter. We define a tolerance interval of 5 millimeter above and below. Success was defined as a resection in safe margin, and failure was defined as an intralesional resection, so a cutting within the tumor. Accuracy has been expressed in terms of the errors in safe margin in millimeter. In the factors influencing accuracy, we have recruited 10 senior surgeons and 13 junior surgeons. Each surgeon has resected a simulated tumor by following 3 different cutting processes: a freehand process, a navigation-assisted process, and a PSI-assisted process. And each resection was made by means of 4 cuts, 4 different bone cuts located around the tumor. So the complete series of measurement consisted of 276 cuts that we have each digitized with the coordinate measuring machine. Some pictures of the preoperative resection planning, the intraoperative navigation guidance view, and the postoperative measurement of the cut plane of the bone cuts using a coordinate measuring machine. Also pictures from the PSI cutting guide, the preoperative computer-aided design of the cutting guides, then the positioning and the fixation of the guides with K-wires on the synthetic bone model, an example of bone cuts performed with the aid of the PSI cutting guides. In terms of the results, this is the complete series of measurements that we have collected experimentally, so using synthetic bone model. We distinguish between the three cutting processes, the freehand, the navigation, and the PSI assisted process. Each point represents a bone cut performed by a surgeon. So each point represents a resection margin in millimeter performed by one of the 23 surgeons. In terms of trueness and precision, so the bias and the variability in the results, we clearly see that we have the same level of trueness with the three cutting processes. We have the same level of trueness because the mean of each of the three series of measurement, the mean is located very close to the desired safe margin, which is 10 millimeter. But in terms of precision, so the variability among the results, we clearly see that precision is better with navigation and better still with PSI, meaning that navigation and PSI technology allow for a better control of the sources of variability in the bone cuts. Of course, these are experimental data that we collected in preclinical setting on synthetic bone model. So the question is, what could be the clinical relevance of these experimental data? With navigation and PSI technology, we have observed experimentally 0 intralesional resection. But of course, it does not mean that navigation and PSI technology will allow for 0 intralesional resection in clinical situation. But if we compute a statistical model for each of the three series of measurements based on the level of trueness, bias, and precision variability that we have observed experimentally, we can estimate the risk of intralesional resection, the risk of cutting within the tumor, with respect to the level of the desired safe margin, with respect to the level to the surgical target. And then we can build these curves, expressing the risk of intralesional resection with respect to the level in millimeter of desired safe margin, and we are distinguishing between the freehand cutting process in black, the navigation cutting process in orange, and the PSI cutting process in blue. We are also distinguishing between senior and junior surgeon, just to show that each time senior surgeons are performing better than junior surgeons. And then of course, these curves are statistical curves and experimental curves, but it can demonstrate what could be the clinical relevance of navigation and PSI technology. In fact, navigation and PSI would allow for smaller safe margin, for a constant risk of intralesional resection, meaning, for example, that the surgeon could, for example, preserve a joint. Of course, this ISO methodology that we use in preclinical settings presents some limitation for use in clinical routine. The ISO methodology requires that we all agree on the clinically adequate targets, and sometimes we have to deal with a certain amount of uncertainty on target. Clinical outcomes are also multifactorial, and definition of the success and the failure of a surgical treatment is not binary. It is not as simple as cutting in safety margin and cutting within the tumor, of course. So in summary, we just wanted to present an ISO methodology that we implement to quantify the improvements in accuracy in terms of trueness and precision. The ISO methodology requires to define a surgical target and to agree on the definition of this surgical target, and clinical relevance of assistive technology in preclinical settings can be investigate by investigating the effect on a smaller safe zone. Also, just for information, we are initiating a standardization process with the International Society Chaos International. We are organizing a workshop during the next annual meeting of Chaos International next June in Japan. The objective of the workshop is to develop a first white paper document including as a first step a first glossary of terms and definition about accuracy and accuracy measurement method dedicated to chaos, so computer-assisted orthopedic surgery. Thank you very much.